Good afternoon. Can you hear me?
Yes, sir. Good.
Okay, right. Right. Okay. So we can start. And so this is the lecture on defecations. Uh, uh, one last lecture in the physiology of gastrointestinal tract. And these are the ILOs. So it's relatively short lecture. You can read the ILOs leisurely. Relevancy, right? So of course, defecation is normal physiological process, but some alteration like diarrhea, constipation, irritable bowel syndromes, and some abnormalities related to defecations. The relevance of this physiology lecture. So defecations, or when the all the digestive process of the gastrointestinal tract end, we have we have absorbed the content, and then we have something remain, right? So we need to remove that content from the body, or feces. We need to remove the feces, but the process of removal of feces, or we can call it defecations, more physiological term. So that process is well regulated, controlled process, especially in the developed animal like human. It's a very controlled process. So therefore, the defecation, we can call it autonomic spinal reflex, because most of the part of the defecation is a reflex, but that can be voluntarily inhibited. Or if we want to inhibit that reflex, by keeping external sphincter contract, or facilitated voluntarily, we can facilitate it that by relaxing in sphincters, or and doing some voluntary activity like contraction of abdominal muscle. So process of defecation is, of course, it's most of the part, or main part is a spinal reflex. That means reflex operated through the spinal cord. Right. So you learn about the many reflexes in the gastrointestinal tract or gastrointestinal physiology so far. And this one also is a reflex. But that we can either inhibit if you want, or if you want, it can be facilitated. So that's probably you can understand. Defecation, we can keep inhibited when the time comes. Or if we want, if we feel that it's time, or even if we feel that now it's uh, uh, now we should do, we can initiate that. So it's a controlled reflex. And when we think about this defecation process, we need to consider about the two sphincters, two valve, let's say two valve. One is internal sphincter, right? So that is inside the end of the anus. We have, let's say this is internal sphincter, right? So if it is a narrow tube, we have internal sphincter, and we have external sphincter, right? So there are two types of sphincter. Internal sphincter, as many places, smooth muscle and involuntary. If it is smooth muscle things, we cannot control voluntarily, so it's an involuntary thing. And if it is involuntary, it regulated by autonomic nerve system, that means sympathetic and parasympathetic system. So this internal sphincter can be regulated by sympathetic as well as parasympathetic. So we know that almost all the activity in the gastrointestinal tract facilitated by parasympathetic, right? And inhibited by sympathetic. So here also sympathetic nerves contracting in sphincter, that means keep it close, and parasympathetic relax the sphincter, internal sphincter, right? But this sphincter is, I would say, is a useless sphincter. Because when the rectum fill or distended, it's almost, it will open spontaneously. I mean, we cannot control it, right? When it comes to a certain pressure limit in the rectum, this will automatically relax and we don't have control, and it will automatically relax. But of course, it has sympathetic and parasympathetic supply. So that about the internal sphincter. Then we have external sphincter. This one, that is consists of skeletal muscle, right? So if it is skeletal muscles, how about the control? Any skeletal muscle things? How can we control them? Or can we control them? Can we think
Yeah.
and do? Yes, we can think and do. We can relax or contract, like in our muscles in the limbs and arms and things, right? It's a voluntary things, skeletal muscles and voluntary. So therefore we can control, right? So it's supplied by pudendal nerve. You will learn in anatomy. And these contractions, we can contract or relax. So this external sphincter, voluntarily we can keep contracted, right? If we want, we contract and close the gate. And if we want, we can relax and open the gate. So that type of conscious controlling sphincter, external sphincter. So when the time comes, we can relax it and open. Until time we can contract and close, right? So these two sphincters are important for the defecation's mechanism for the control of this action of defecation, right? Right. So usually, I mean, when we can say usually rectum is empty, because most of the content in the gastrointestinal tracts are in the, of course, with the meals, it will come to the stomach, small intestine and large intestine, and most of the time content will be in those places, right? So we can say rectum is empty. But gradually, rectum start to fill, right? So it's a when the content from the large intestine, descending colon, sigmoid colon and things, gradually will push the content to the rectum. So and rectum, when the content in the rectum added, when with the filling of the rectum, rectal pressure increase. So it's a rectal pressure come to this level, 18 mercury millimeter, the internal sphincter, we get the feeling of, we get the desire to fill, right? Feeling desire or urge to defecation, right? So when the rectal content, with the adding of the content to the rectum and the rectal pressure increase, You know, when the things come to anywhere, pressure will increase. And when it come to this 18 mercury millimeter, we get the feeling. But that is not a problem. And we have good voluntary control over our external sphincter. That just a feeling. And we can forget it. But with the adding of more content, pressure will increase. But still, we voluntarily we keep the internal sphincter closed. But when the rectal pressure come to 55 mercury millimeter, it say beyond that uh, the sphincter cannot be keep close. So that means it's a heavy pressure, right? So usually we don't get that much of pressure. Unbearable pressure usually we don't get, right? Of course, up to this level, we voluntarily keep it close. That means external sphincter will we keep external sphincter close, right? So about the regulation of the GIT, the most of the places probably when we discuss about the regulation of the muscles, I think I already mentioned that there's an intrinsic property of the smooth muscles. That is just without any help, to some extent, smooth muscle can work. Then we have voluntary reflex action, which is operate within the gastrointestinal tract, right? Local reflex. Probably I mentioned in the stomach, we have local reflex. With the distension of the stomach, there's an activation of reflexes in the nerve reflexes in the wall of the stomach, and contracts or relaxation secretions can we can get that secretion, contraction or relaxation, that those action purely by the reflex operated in the wall of the gastrointestinal tract. Then that we can call intrinsic effect. Then there are some other reflex which will operate with the help of brain or spinal cord. So that those reflex also I mentioned when I talk about the stomach. For when the food come, stomach will relax through a involvement of brain. So I mentioned about the vagovagal relaxation. Stimulate the vagus nerve when the food come, send impulse to the brain, again through the vagus nerve, relax the stomach. So that is reflex involving central nerve system. So basically, this reflex involves central nerve system, and this reflex involved on in the wall of the gastrointestinal tract. So we call intrinsic reflex. For the defecation also, these two will operate, right? So therefore, we can call defecation three-part for the purpose of studying. That is a reflex involving neuron in intrinsic to GIT. So that means purely reflex operate through the wall, right? Some stimuli reflex in the nerve flexus and effect also in the wall. So that is a intrinsic reflex. Then we have spinal cord reflex or external reflex. Distension will send impulse to the spinal cord. Let's say cross section of spinal cord, come and distend or contract in the wall. So that's a spinal cord mediated reflex, or we can call external reflex. And then we have voluntary component, not these two. As I mentioned earlier, external sphincter, purely voluntary control, that it's not really reflex, we will do, think and do, right? So basically defecation, we can see these three parts. right? So I will explain these three part in next few slides, right? So so what happened with the, as I mentioned early, when we get the meal after 3 hours, considerable amount will come to the rectum. So it's sorry, considerable amount come to the large intestine, right? So uh, some content will be in the large intestine, like descending colon, sigmoid colon, and so on. Things will come to this area, right? So when the things come to this area, so as I mentioned earlier, rectum is empty almost. I mean, rectum is empty most of the time. When the things come to this area, there are some contraction specific to this area, like probably uh, you remember I mentioned about the mass action of contraction or mass contraction. Mass contraction is only in the large intestine, where content will push toward the rectum, right? Those are not very frequent. When the content come to the large intestine, mass contraction will move content towards the rectum, right? So this will distend the wall of the rectum and the sigmoid colon, and so in this area, wall will distend when the things will push down to this area, right? And of course, when the wall will distend, that will initiate the reflex, right? Of course, to push the content to this area, peristaltic also will help, and mass action of contraction uh, will help, and so those normal activity of the large intestine will help to push the thing towards to this area, to the rectum and lower part of the large intestine. So rectum will distend. With the distended rectum, initiate from reflex activity, uh, mainly intrinsic reflex, right? So with the uh, yeah, this intrinsic reflex operate in the wall of the uh, track, right? So wall with the distension, some sort of contraction will occur. That contraction will push down to things towards the rectum, right? Right. So that is the initial intrinsic reflex. So as I mentioned earlier, intrinsic reflex is purely reflex operate in the wall of the GIT tract, sigmoid colon, rectum, and so on, right? So this will push down content to the rectum. Then we get the external reflex, right? So external reflex is with the involvement of spinal cord, right? So for the external reflex, we have receptors in this area, right? So here you can see afferent, right? So these are right. So yeah, these are afferent sensory information, right? So this distension of the rectum will send impulse to the spinal cord, and then efferent from the spinal cord will go to the wall of the sigmoid colon, rectum, and so on, will make a contraction, right? So that is real defecation reflex, right? So in this diagram, same thing, with the distension of the distension and stretch of the rectal wall due to movement of feces into the rectum, that will increase the pressure or stimulate, or those that will stimulate the pressure receptor and initiate this afferent, right? This afferent, and then through the spinal cord, it will come the efferent spinal reflex, intrinsic initiate, which with the parasympathetic motor component, and rectal wall, contraction of the rectal wall and relaxation of internal sphincter. So relaxation of internal sphincter, I already mentioned. This rectal wall will contract, right? Because now rectum try to push the content towards the anus, right? So rectal wall and probably sigmoid colon wall will contract and try to push the content to the rectum, right? And that will increase the pressure further, and we will get the feeling. We will get the feeling of fullness. And of course, when it comes to certain level, internal sphincter will relax. Pressure will increase in the rectum, internal sphincter relax, but still nothing will happen, right? But we get the feeling, right? So we can control by this external sphincters, which is skeletal muscle. We can contract them and we can control, right? In this diagram, almost same thing. Both diagram almost same thing. In external sphincter, we can control. So in the defecation reflex, we have afferent sent to the spinal cord. We have efferent coming to the wall of the rectum and probably part of the sigmoid colon, and that will contract, right? So by contracting rectum and probably upper some part of the sigmoid colon, things will push down, try to push down. But here we have external sphincter, keep it constant. Pressure will increase gradually, right? So so this external sphincter with the time, strong external defecation reflex will occur when the pressure increase. When the pressure increase, reflex will be strong, and we will feel it that some sort of forceful reflex we will feel, but we can keep it controlled, right? So it's a afferent mechanoreceptor in the rectal wall, efferent in the smooth muscle, forceful, that forceful contraction will move feces toward the anus. Right. So it's a strong contraction wave approach to the inner, and internal sphincter will relax. But don't worry, nothing to worry. Internal sphincter is useless. As I mentioned earlier, it is useless. It just relaxes with the increased pressure. But so we wait and wait. When the time comes, that means you can understand, we go to the toilet, and when the time comes, now we need to initiate that. Now we need to really empty the rectum. We need to really empty the rectum, right? So when we want to really empty the rectum, we can do something to make this reflex strong, right? We can voluntarily increase this pressure inside the rectum, right? By contracting abdominal wall, we can increase the abdominal pressure. That means pressure surrounding the rectum, right? So when we increase the pressure in the abdomen, rectal pressure also increase, and then we get the strong defecation reflex. Because now it's ready. Now we need to push anyway, right? So we know that we can do straining, tatamano again, right? Increase the abdominal pressure, do some put some effort, and same time we can relax the wall of the perineum, right? So perineal bone. And in addition to that, there's something called, there's an angle between rectum and anus, right? So this is the anus, this is the rectum, right? And this angle, we can make it straight, right? So usually this angle is like this, we can make it straight, and then it is to push the content toward the anus. So this is the anus and this is the rectum. Rectoanal angle, we can make it straight. This is the normal, and this is during straining or during real act. We can make it straight. And we can relax the wall of this perineal wall. And now we can increase the pressure in the rectum, as I mentioned earlier, by straining. And most important thing, we can voluntarily relax the external anal sphincter. And then content will push down and move out. The feces will move out. So you should be able to understand now, during act, something will occur. But defecation reflex even start before the act. Before real defecation, before we really empty the rectum, defecation reflex start. Contraction start because of the increased pressure, and pressure receptor or mechanoreceptor detect the pressure, and reflex will operate. This reflex will operate. But this voluntary act prevent that. But when we really come to the real act of defecation, when we really start to do the things, we can do many things voluntarily. We can increase abdominal pressure voluntarily. By increasing abdominal pressure voluntarily, we increase the rectal pressure. Increased rectal pressure will initiate strong defecation reflex. Those involuntary reflex we can aggregate, right? So we can straight the recto anal angle, right? And we can relax the external sphincter, and we can relax the perineum, and so those things we can do voluntarily, right? And then content will go down, right? If you sometime probably you know that we need to put the extra effort, and because some content in the rectum, we need to push to the anus by initiating strong defecation reflex. To initiate strong defecation reflex, we will increase the rectal pressure, right? Of course, increased rectal pressure will push the thing down and get the strong defecation reflex. That strong defecation reflex also contract the rectal wall and push the thing down, right? So, so these things will occur during the act, and with the relaxation of the sphincter, things will go down, right? So that you can watch this video, and in your handout you can see, I think, this URL. So that is the act of defecation, right? It has a defecation reflex, and during act, it has some voluntary actions, right? So it's a defecation reflex. It's actually involuntary part, right? Basically, it's a small internal component, intrinsic reflex, and external reflex operate through the spinal cord, right? So then, right. So during act, what happened, you can read, and so that is defecation. Right, so there is something called gastrocolic reflex. That also probably you have sometime experience. When the content come to the stomach, when the stomach get filled, sometimes we feel the desire to defecate, right? And that reflex will operate through the nerve reflex, and probably with the help of gastrin hormone, action of gastrin hormone. When the stomach get filled, reflexly we initiate the defecation reflex. Especially children's, that is obvious, and that is why in children's, probably infant or neonates, when they feed, they start to defecate, because with the feeding, with the distension of stomach, they can initiate the defecation reflex by this gastrocolic reflex. Gastrocolic mean distension of stomach, gastro, initiate the reflex contraction of large intestine or rectum in that area. Of course, with the age, we will condition these reflex. Many things, many reflex we can condition, right? We can control, right? Voluntary reflex also we can control and condition, and then we can overcome this gastrocolic reflex. So that is why adults, it's not a problem. But sometimes we feel that, sometimes we get that, right? Then I will discuss two conditions, diarrhea and constipation, because those are related to defecation, and clinically it's very important, right? Many patients come with diarrhea due to many problems, right? Diarrhea is watery stool due to rapid movement of fecal matter through the large intestine, right? So diarrhea is basically watery stool, right? So you need not to mention, you already experienced that diarrhea is a watery stool. Of course, some diarrhea, special condition, blood and mucus or blood distain diarrhea, mucus content diarrhea, or blood and mucus diarrhea, or different varieties, but basically it's a watery stool. Mechanism. There are many mechanisms for the diarrhea and how we get the watery stool. One mechanism is high osmotically active content particle will retain water in the intestine, small intestine, large intestine, and so on, and stool get water. Good example is lactose intolerance. You learn about the lactose intolerance. We cannot digest lactose, so lactose will retain there, and that is a osmotically active particle, and that will retain the water and make diarrhea, right? Many digestive abnormalities will lead to diarrhea because of this osmotically active particle. We cannot digest the particle. Maybe fat, difficulty of digesting fat, maybe difficulty of digesting protein, maybe difficulty of digesting carbohydrate. Then these particle we cannot absorb, and particle will retain in the gastrointestinal tract, small intestine, large intestine. When we have osmotically active particle, that will retain water. That is normal, isn't it? When we have osmotically active particle, that will retain water, right? So we can, if this is gastrointestinal tract, if we have many particle than normal, undigested particle, that will attract the water. That will attract the water, and water content will increase. So now finally we get the feces with water, diarrhea. And in some condition, so that is osmotically active particle, in some condition secrete large amount of water and electrolytes. So water will secrete to the lumen and electrolyte will secrete to the lumen. In some condition like cholera, that will happen. Of course, cholera is a very, very rare condition now in this country, but that's what happened. It start to secrete water and electrolyte. So just secretion will increase content. Sometimes increased mortality also can lead to diarrhea, right? If the mortality will increase, we don't have time to absorb, and things will more water and retain. Like sometime in thyrotoxicosis, right? Thyrotoxicosis, you will learn later, increase thyroxine hormone level probably might make diarrhea because of increased mortality of the gastrointestinal tract. Of course, poor absorption, as I mentioned earlier, poor absorption, then the particles will retain water, get poor digestion also same. If there's a deficiency of some digestive hormone, that will retain the particle and absorb water and make diarrhea. In addition to that, inflammation, viral, bacterial infection, make inflammation in the wall, and wall will not be normal, right? Absorption mechanism will not be normal because of the inflammation due to bacteria and virus. Then things cannot absorb, right? And then again, things will retain and pass it as a loose stone. So that is the mechanism for most of the diarrhea that you experience. Most of the diarrhea, 90% of, probably more than 90% is due to viral origin, and settle in 2-3 days. And probably that is due to inflammation in the wall. Right? Mucus become irritant, and increased rate of secretion and motility in the intestine will usually make diarrhea. Right? So with the inflammation, things will not absorb, and motility also will increase, and watery stool will finally will come out. Very rarely there are condition called inflammatory bowel disease. So in this bowel wall, we get inflammation, damage, ulcerative colitis, and there are some other condition like ulcerative colitis, where also bowel wall is not normal, and that will make diarrhea. Right? I already mentioned about the lactose intolerance and acid damage to the mucosa. When the acid damage to the mucosa, we cannot absorb, and can lead to the watery stool. Right? So there are many mechanisms for the diarrhea. Right? Depend on the factor, that might vary, but most common types we can see with the virus or bacteria, probably with the food poisoning. ජරාව කෑවහම නරක වෙච්ච කෑම කෑවහම we probably get the bacterial problem with the spoiled food, and commonly viral disease. So those are the mechanism for develop watery stool in different due to different reasons. So that one end is diarrhea. So other end is constipation, right? Opposite, right? Constipation refer to a pathological decreased bowel movement. Pathologically, right? Bowel opening or defecation is poor, right? So, but remember, once in 3 times, or once in or 3 times a week also probably normal. So once in every 2-3 days, so 3 times a day, still normal. Some might defecate 3 times a day. Probably that is normal. Some might defecate once in 2-3 times, once in 2-3 days. That also normal. So we don't consider these are constipation, but probably that is normal. But if suddenly bowel habit change and start constipate, probably we need to consider possible pathological or underlying cause. Right? However, persistent constipation, but particularly those with recent changes in the bowel habit should be examined, rule out the underlying causes for constipation. Probably malignancy can lead to constipation or hypothyroidism. Right? So as I mentioned that hyperthyroidism or increased thyroxine level will make diarrhea. Decreased thyroxine hormone level or hypothyroidism lead to constipation because decreased gastric motility, bowel movement. Right? So you will learn more about the constipation in the paraclinical and clinical years, and just keep this in mind. And for the treatment, increase dietary fibers, very important. Before we really go to the drugs, increase fiber content foods, and so on. And then laxative or some factors that increase the bulk of stool, and stool lubricant like some syrup will facilitate the loose stool movements are the treatment option. Right. So that is the lecture on defecation. Any questions? If there's any questions, you can ask. Right. So it's 45 minutes or 46 minutes or sorry, 40 minutes. Yes. If there's any questions, you can ask. Right. So most important part is try to understand the defecation reflex, especially this external reflex operate to the spinal cord, and what happened during the act. What is the facilitatory process during the act of defecation, right? Then constipation, diarrhea, those things important. And by the way, what are the other reflexes you learn so far in the gastrointestinal tract other than defecation reflex? Samanada reflex igana gatte in the gastrointestinal tract. What are the activity that will operate as a reflex? මොනවද තව රිෆ්ලෙක්ස් විදියට වැඩ කරනවා ඉගෙන ගත්තේ? මොකුත් නැද්ද?
Swallowing reflex.
Sorry? Swallowing reflex. Yes. Pharyngeal phase of the swallowing. Yes, good. What else? Yes. Any other reflex activity in the gastrointestinal tract? Related to stomach?
Gastric reflex.
Sorry? තේරුන්නේ නැහැ. Yes? මොකද්ද?
Gastric reflex.
Gastric reflex? Yes. Yes, probably when the food come, we learn about the receptive relaxation of the stomach. Stomach will relax. Then for the acid secretion also, there's a reflex operate for the acid secretion. Some of them are conditional reflex. And probably you learn about the gallbladder contraction, that will also operate as a reflex, vagal reflex. So many reflexes. And in other places, in other system, you will learn many more reflex related to bladder function, related to reproductive functions, and so on. Okay, so I will stop now.